Hello, my name is Nathan Lung. I am one of the teaching fellows at Musgrove Park Hospital, and this is my quality improvement project on neck and femur fractures. It's an educational QIP, 3 cycles on medication management perioperatively to reduce avoidable hypertension and in theory reduce acute kidney injury. So just some background then. So hip fractures, unfortunately, are very prevalent and increase with age. They are very common and often they are life-changing events and economically burdensome and very challenging to all healthcare systems amongst the world. The most leading cause of hip fractures are falls, and actually patients older than 80 unfortunately have high morbidity and high mortality risk following hip fractures. The hazard ratio for men is about 7.95 and for women is about 5.75 respectively. So the failure then to stop and identify certain medications in the perioperative phase has been associated with worse prognostic outcomes, and this includes again increased morbidity and increased risk of death. The study found that patients 1 in 20 suffered from adverse drug events following hip surgery after failing to stop medications in the perioperative phase. And actually of these cases, 80% were preventable. There was a separate study involving about 1,000 patients, surgical patients, and actually patients on 1 or more long-term medications for their chronic disease were about 2.5 times more likely to suffer from post-op complications compared to those not on medications. So this highlights, that it's really important to try and mitigate the risk by identifying these medications perioperatively and stopping them appropriately. We know that one of the driving risk factors for acute kidney injury, specifically post-op AKIs, is intraoperative hypotension. And many of the medications that patients are on nowadays are linked with hypotension or can cause hypotension. So, medications like antihypertensives should be identified and stopped really. There was a study that found that amongst 162,000 surgical hospitalizations, there was post-op AKI in around 12% of these patients. And about 3/4 of these patients with post-op AKIs had stage 1 AKI. And most of these AKIs are avoidable and predictable. So, like I mentioned before, there are certain medications like antihypertensives, particularly ACE inhibitors and ARBs, or angiotensin receptor blockers, and these are linked to intraoperative hypotension, and they drive post-op complications such as reduced perfusion to tissue, myocardial injury, sometimes stroke, and also AKI. There are similar effects noted with other agents like calcium channel blockers, which cause vasodilatation, and there are other medications, anti-diabetic medications, such as SGLT2 inhibitors that are associated with euglycemic ketoacidosis, but also others like biguanides that can precipitate lactic acidosis in patients with poor renal reserve. And then lastly, diuretics as well can worsen renal function by reducing renal perfusion, and that can also lead to AKIs. It's important not to forget common things like antiplatelets and anticoagulants, which should be stopped before surgery to reduce intra-op and post-op bleeding. And so my 3-cycle QIP really was to better educate resident doctors amongst the orthogeriatric department around perioperative medication management to try and mitigate the risk of AKIs and other organ injuries. So my method was it was a 3-cycle QIP, and cycle 1 was about identifying a need for change. So a preliminary questionnaire was formed, and this was asking resident doctors to tick box which medications they thought should be held perioperatively. So of the medications presented, there were medications like furosemide, levothyroxine, clopidogrel, ramipril, losartan, bisoprolol, prednisolone, dapagliflozin, gliclazide, metformin, and carbimazole. And all these medications are quite common amongst elderly patients, and we see them quite a lot. And so cycle 2 was about really working on what cycle 1 found, and cycle 1 found that there was preliminary lack of knowledge around stopping medications. And so in cycle 2, I designed a 15-page booklet around medication management, and this touched on pharmacology of medications, pharmacodynamics, and also spoke about neck of femur fractures in general, and the principles of orthogeriatrics. It was quite a comprehensive booklet, and if you'd like to take a look, I've got a QR code down below which will link you straight to my booklet. And at the end of cycle 2, I was incorporating the feedback based from peer feedback, and I amended the booklet, removed some chapters, and added in some chapters that I thought were more relevant. And then cycle 3 was more about trying to make my project and my booklet more accessible, and to also raise awareness about medications to stop. So I did two things. I created a poster and I circulated this around the orthogeriatric wards. And the poster, as you can see below, had the medications that should be stopped perioperatively, and also had a QR code that facilitated digital access to my booklet. And so I didn't have to give physical copies out all the time to rotating cohorts of doctors. So the results showed that there was a lack of awareness around stopping certain medications, and in particular, we saw that actually doctors failed to stop medications such as metformin. So all of doctors in cycle 1 failed to stop medications like metformin, and most doctors as well, 60%, failed to stop medications like gliclazide. And several doctors, or one doctor actually, forgot to stop medications like dapagliflozin. But actually, conversely, the cohort knew to stop medications like ARBs, clopidogrel, and furosemide. Cycle 2 then had some more mixed results actually. So in terms of medications to stop, so 20% more stopped SGLT2 inhibitors or dapagliflozin, and actually with my booklet in place, many more doctors knew to stop bigonides or metformin, a medication that can cause lactic acidosis and worsen renal function. But I think still in cycle 2, candidates still forgot to stop medications like antiplatelets and sulfonylureas. So antiplatelets can confer increased bleeding risk, and with sulfonylureas, as part of sick day rules for diabetics, they should be stopping these anti-diabetic medications before surgery. Cycle 3 then, so after the implementation of my booklet, my posters and my QR codes, probably saw the best results. So actually, compared to cycle 1, there were 20% less prescription errors, and compared to cycle 2, there were just much better results in general. Most doctors then knew to stop sulfonylureas and antiplatelets, which they failed to do in cycle 2. And almost nearly, in fact, all of the doctors in this cohort knew to stop diuretics, a medication that can worsen kidney function, and they knew to stop antiplatelets, anticoagulants, and also antihypertensives like ACE inhibitors and ARBs. Medications like bigonides, sulfonylureas, and SGLT2 inhibitors were also stopped. So in general, the feedback that I got from cycle 3 was that, and this was open feedback in my forms, was that junior doctors or resident doctors reported increased knowledge and confidence in medicine management in neck or femur fracture patients. And I attribute these results down to my educational interventions between each cycle. So in conclusion, my 3-cycle quality improvement project, I think, has done several things in that it has inspired confidence in resident doctor clerking, and for them to know which medications to stop in the perioperative phase. It's also good education. And whilst we do cover this in the medical school curriculums and also in training, I think it's always good to revisit it. The cycles are still ongoing, so actually I'm carrying out a 4th cycle, and this time I'm trying to incorporate more face-to-face teaching, and I think again that will try and bolster the scores a little bit and results. I think there's always room for improvement, and now that I'm not doing orthogeriatrics and I've moved on, I've passed on my project to a colleague of mine who's continuing my project, and we're working on this together. But it's still a project that we're working on, and I think there's still room for improvement. Yes, I'm open to any questions, and hopefully during the active presentation I can answer your questions. Many thanks for listening. Thank you very much.